Welcome to the Funnel Effect.
Thanks. It is really good to be here today.
Today we are discussing the landmark paper titled Randomized Trial of Intravenous Streptokinase, Oral Aspirin, Both or Neither, among 17,187 cases of suspected acute myocardial infarction, ISIS-2 effects. This report was produced by the ISIS-2 collaborative group and published in The Lancet on Saturday, August 13th, 1988.
Yeah, and this is, without exaggeration, this is one of the most important medical papers of the entire 20th century. It fundamentally changed how we treat heart attacks.
I really want to start by setting the scene properly for this deep dive because 1988 feels like a lifetime ago in terms of technology.
Oh, absolutely.
But in medical terms, it is really the foundation of the modern era. We often think of the late 80s as like the time of big hair and synthesizers. But in the emergency rooms, it was a time of serious, intense debate.
It was a time of what I would probably call constructive confusion. We were moving out of an era where a heart attack was seen as something you just had to endure into an era where we realized we could actually intervene. But we didn't quite know how to intervene safely, or even if our interventions were doing more harm than good.
So let's paint the picture of the medical landscape regarding heart attacks for the listener, or acute myocardial infarctions, MI, as the paper calls it.
Right, the clinical term.
Yeah.
Yeah.
If I had a heart attack in, say, 1985, just 3 years before this paper came out, what was the prevailing theory in the ER?
That is a great question to ground us. So for a long time, the focus was almost entirely on the electrical system of the heart.
Not the plumbing.
Exactly, not the plumbing. The belief was that people died from arrhythmias, irregular heartbeats. So we put them in these quiet rooms in the coronary care unit.
Just to keep them calm.
Mostly, yeah. We gave them lidocaine or other antiarrhythmics to stabilize the electrical signals, and we just watched them. There was actually a huge debate about whether the blood clot, the thrombus, was the cause of the heart attack or just a consequence of it.
Wait, really? That seems wild to think about now.
I know it does.
Because we know now that the clot blocks the artery, which starves the muscle of oxygen. But back then, they weren't sure if the clot was the primary villain.
They honestly weren't. Some thought the muscle died first for some other reason, and then the stagnant blood just clotted afterward as a side effect. But by the mid-'80s, the thrombogenic theory, the idea that the clot is the actual cause, was really gaining ground.
Okay, so the paradigm was shifting.
Slowly, yes. We started getting angiography studies that showed these blocked arteries in the very early hours of an attack. So the logic naturally shifted. If a clot is the problem, we need a clot buster.
And that is where the interest in fibrinolytic therapy started to heat up.
Precisely.
Let's break that word down for you listening at home before we go any further. Fibrinolytic. Fibrin is basically the mesh that makes the clot, right?
Yes, the structural protein net.
And fibrinolysis means to cut or dissolve, like lysis.
You got it. Fibrinolysis is just the process of breaking down clots. Now, the human body does this naturally, of course, but it does it very slowly. It takes days or weeks.
And you don't have days during a heart attack.
You have minutes. The idea here was to inject a drug that accelerates that dissolving process incredibly rapidly to restore the blood flow before the heart muscle actually dies.
So prior to ISIS-2, there were other trials, right? It wasn't like this concept just dropped out of the sky in 1988. There was something called the GISI trial.
Yeah, the GC1 trial over in Italy. And that was a massive deal at the time. It showed that streptokinase, which is the main drug we're discussing today, reduced mortality.
But I hear a but coming.
But science is highly skeptical by nature. One trial is good, but is it reproducible? GC had some open questions regarding the timing of the drug in certain subgroups.
Plus, there was a lot of noise from other studies, right?
Oh, a ton of noise. There were dozens of smaller trials floating around. You'd have one with 100 patients here, another with 300 patients there, and they all showed conflicting results.
Which is confusing for a doctor just trying to save a patient.
Incredibly confusing. Some of these small trials showed a benefit, some showed absolutely nothing, and some even suggested the bleeding risks from the clot busters outweighed any heart benefits.
That is the exact kind of statistical noise we talk about when we look at data. Like, if you flip a coin 10 times, you might get 8 heads just by chance, and you might think the coin is rigged.
Exactly.
You have to flip it 1,000 times to see the real truth, to see it settle at 50-50.
That is a perfect analogy.
Okay.
And that brings us directly to the core mission of ISIS-2. By the way, the acronym stands for the Second International Study of Infarct Survival.
Catchy.
Very 80s. The goal of this group was to settle the debate once and for all They needed a sample size so massive that all that statistical noise you just mentioned would completely disappear.
Leaving only the signal.
Right, leaving only the undeniable truth of whether the drugs worked or not.
And they aimed for 20,000 patients, which is just staggering. They ended up with 17,187.
Which was unprecedented.
That scale is just, it is hard to even comprehend for a medical trial, especially back then. Usually a few hundred is considered a pretty decent paper.
To understand why they needed that many, we have to talk about a concept called statistical power.
Okay, let's get into it.
If you have a drug that cures a disease with a 100% death rate, like, say, untreated rabies, and you give the drug and you save one person, you know immediately that it works.
Right, the Lazarus effect. You don't need a massive trial for a miracle.
Exactly. But in heart attacks, even back in the 80s, most people actually survive the initial event. The mortality rate in the hospital might be around 13 or 15%.
So most people are living anyway.
Right. So if you have a drug that reduces that mortality from 15% down to, say, 10 or 9%, that is what we call a moderate reduction.
But on a global scale, that saves millions of lives.
It does. But the problem is, in a small trial of 100 people, you might not see that reduction at all. It gets lost in the random chance of who walked through the door that day.
Because maybe you just got a batch of really sick patients.
Exactly. To detect a 20 or 25% relative reduction in mortality with absolute ironclad certainty, you need thousands and thousands of events.
So they needed a massive net to catch this moderate but highly significant benefit. Let's talk about how they actually built this net, the architecture of ISIS-2.
This is where the sheer genius of the study design shines through. It was a logistical masterpiece.
We are talking about 417 hospitals across 16 countries.
The UK, the United States, Canada, Australia, New Zealand, Belgium, West Germany, Italy.
And coordinating all of that in 1988 without email.
No email, no internet, no smartphones, no cloud databases.
I was reading about the randomization process in the paper, and it blew my mind. Today, a doctor would probably punch a few details into an iPad, an algorithm runs, and spits out a group assignment. How did they do it then?
The telephone.
Just normal phones.
Just regular landline telephones. They set up these 24-hour telephone services in hubs like Berlin, Lyon, and Oxford.
So picture this for a second. Imagine you are a doctor in a small rural hospital in the north of England. It is 3 in the morning. A patient comes in sweating, clutching their chest.
The classic presentation.
You examine them, you run an ECG, you think it is a heart attack, but you aren't totally sure about what treatment to give.
So the doctor literally walks over to the nurse's station and picks up the landline. They dial the international number for the ISIS Center.
And a human being actually answers at 3 a.m.
A human operator answers. The doctor gives the patient's name and a few incredibly basic details. The operator at the center checks a physical list or a very early computer system and says, okay, this patient is allocated to treatment box number whatever, and gives them a specific code.
And that code corresponds to the actual physical drugs found down in the hospital pharmacy.
Actually, to make it even simpler, they had already sent physical treatment packs to all the participating hospitals.
Oh, so it was right there in the ER.
Right there. So the operator would just say, use pack number 452. The doctor grabs that specific box off the shelf, opens it, and inside are the vials and the tablets.
That is brilliant. It completely removes the complexity of the doctor having to measure doses or mix different things under high stress.
And that leads directly to the core philosophy of this trial, the simple protocol. The paper emphasizes this word over and over. Simple.
Why was that so crucial? I mean, medical trials are usually famously complicated.
Because complexity kills compliance. If you ask a busy emergency room doctor at 3 a.m. to fill out a 10-page form in triplicate, draw 10 extra vials of blood, and wait for 3 hours of lab results before they can even enroll a patient.
They just won't do it.
They absolutely won't. They have other patients dying. They will just treat the person standardly and ignore your trial.
The paper actually mentions the entry form was just one single page.
It was incredibly sparse. And the discharge forms were simple, too. They didn't ask the doctors to track 1,000 different tiny variables.
What did they ask for?
They essentially asked, did the patient die? Did they have a stroke? Did they have a major bleed? Very simple binary outcomes, yes or no.
And that low barrier to entry is what allowed them to recruit 17,000 people.
Precisely. If they'd used a standard, complex academic protocol, they might have gotten stuck at 2,000 patients and completely failed to find the statistical answer they needed.
Now, there's a concept here that I found really fascinating and honestly a bit dramatic when you think about the life or death stakes, the uncertainty principle.
Oh. Yes. This is really the ethical core of the whole trial.
Because usually a trial has very strict inclusion criteria. You know, the patient must have exactly this blood pressure, must be within this age range, must have this specific lab value. ISIS-2 basically just said, if you, the doctor, are uncertain, they are in.
Right. It acknowledges the massive gray zone of actual clinical medicine.
How did that work in practice?
Well, if a doctor looked at a patient and said, this person is actively bleeding from a stomach ulcer, I know for a fact I should not give them a powerful clot buster, then that patient was excluded.
Which is completely ethical. You don't give a dangerous drug if you know it will hurt them.
Exactly. Conversely, if a doctor looked at a patient and said, this young person is dying in front of my eyes right now, I strongly believe streptokinase is their only hope, I know I must give it, then that patient was also excluded from the trial.
Because it would be unethical to risk them getting a placebo.
Right, so the trial was exclusively designed for the patients, where the doctor stood at the bedside, looked at the chart and thought, I genuinely do not know if these drugs will help or harm this specific person.
That takes a lot of humility. To admit as a highly trained physician, I simply don't know.
It does take humility. And it turns out that state of uncertainty applied to tens of thousands of patients globally. The trial essentially weaponized that clinical humility to generate rock-solid data.
I love that phrasing, weaponized humility.
It really was.
Let's move to the statistical design itself, the 2x2 factorial design. Now, this sounds a bit like high school math, but it is actually a beautiful way to do science. Can you break this down for us?
Think of it this way. You have two burning questions. Question 1, does streptokinase work? Question 2, does aspirin work?
Simple enough.
The traditional way to answer that is to run trial A, which tests streptokinase against a placebo, and then you run trial B, which tests aspirin against a placebo.
Which means you need two completely separate groups of thousands of patients.
You need double the patients, 2 different funding streams, double the administration, double the time.
It's highly inefficient.
Extremely. So the factorial design says, let's test them both in the exact same group of patients at the exact same time. You divide the 17,000 people into 4 distinct groups.
Okay, walk me through the 4 boxes.
Group 1 gets active streptokinase plus dummy aspirin pills. Group 2 gets active aspirin pills plus dummy streptokinase infusion.
So each gets 1 real drug and 1 fake drug.
Right. Then Group 3 gets both real drugs. And Group 4 gets both dummy drugs, the double placebo.
So every single patient gets an IV infusion and every single patient swallows pills. It is just a matter of which ones happen to be the active ingredients.
Exactly. It maintained the double-blind setup perfectly. And here is why it is so powerful mathematically. When you want to see if streptokinase works, you compare everyone who got the active infusion, that is groups 1 and 3, against everyone who got the dummy infusion groups 2 and 4.
I see. You just lump them together based on the IV bag.
Yes. That gives you your definitive answer for streptokinase. Then you reslice the data. You compare everyone who got the active aspirin pills groups 2 and 3 against everyone who got the dummy pills groups 1 and 4.
And that gives you the answer for aspirin. It is literally like getting 2 massive trials for the price of 1.
It is. But it is actually even better than that. It gives you something 2 separate trials could never, ever give you: the interaction data.
What do you mean by interaction?
It tells you what happens when the drugs meet inside the human body. Do they work well together? Or do they interfere with each other? Do they antagonize each other and cause terrible side effects? Or do they have synergy?
Because maybe taking both is actually worse.
Right. You wouldn't know unless you tested them together. Only a factorial design can answer that question definitively.
Okay, so we have the structure of this massive trial. Now let's talk about the weapons themselves, the interventions. Section 2 of our deep dive.
The tools of the trade.
First up, streptokinase. We established it is a clot buster, a fibrinolytic. But what is it biologically? You mentioned the word strepto, which immediately makes me think of strep throat.
And you'd be spot on. Streptokinase is a naturally occurring protein that is secreted by certain strains of Streptococcus bacteria.
Wait, so we are intentionally injecting a bacterial product directly into someone's veins during a heart attack?
We are. It sounds crazy, but think about it from the bacteria's perspective.
Okay, putting myself in the mind of a germ.
If you are a strep bacteria trying to infect a human tissue, The human body's defense mechanism is to try to wall you off. It builds fences out of clots and fibrin to trap the infection.
So the bacteria is trapped.
But the bacteria evolved this specific protein, streptokinase, to dissolve those fibrin walls so it can break free and spread further through the tissue.
Wow.
So medical science essentially hijacked this ancient bacterial weapon, purified it, and repurposed it to clear human coronary arteries.
That is absolutely metal. It is biological warfare turned into medicine.
It really is.
How does it actually work on a molecular level once it is in the blood? Does it just act like acid and eat the clot?
Not directly, no. It is a bit more elegant than that. Our blood naturally contains a proenzyme called plasminogen. It is just floating around everywhere,
Wow.
totally inactive, waiting for a signal.
Okay, plasminogen.
When you inject streptokinase, it binds to that plasminogen and forms a tight one-to-one complex. And this new complex then goes around the bloodstream, activating other free plasminogen molecules, transforming them into the active form, which is called plasmin.
And plasmin is the active weapon.
Plasmin is the enzymatic scissors. It is the thing that physically chops up the fibrin strands, the structural mesh that holds the clot together.
So the streptokinase doesn't do the cutting itself. It just recruits the body's own scissors to do the job.
Exactly. It triggers what we call a systemic enthylytic state. It activates the body's own dissolving machinery everywhere throughout the entire bloodstream.
Systemic. That implies it has happened everywhere, not just locally in the heart artery where the problem is.
Correct. And that is exactly where the risk comes from, which we will dig into later. Because it dissolves the pathological clot in your heart, sure. But if you happen to have a beneficial clot, say, plugging a tiny cut in your stomach lining or a recent scrape, it dissolves that too.
It doesn't discriminate. It just cuts fibrin wherever it finds it.
Exactly.
The regimen they used in the trial was 1.5 million units infused intravenously over the course of about 1 hour. Is that a large dose?
It is a very high dose. And that was intentional. It was designed to completely overwhelm the body's natural circulating inhibitors and get the job done fast.
Because prior treatments were slower.
Yeah, previous experimental therapies often use slow, continuous drips over 24 hours. The ISIS-2 investigator said, no, time is muscle. We need to blast this artery open right now.
Okay, so that is weapon number 1. Now for weapon number 2, aspirin. The stuff sitting in everyone's medicine cabinet right now. We think of it for headaches or a fever. Why is it in a high-stakes heart attack trial?
Aspirin, chemically known as acetylsalicylic acid, is a fascinating drug. In this context, it works by inhibiting an enzyme called cyclooxygenase, or COX.
I feel like I'm suddenly back in college biochemistry class. What exactly does the COX enzyme do?
COX is responsible for producing a chemical called thromboxane A2 inside your platelets.
Platelets being the tiny blood cells that start the clotting process.
Right, the first responders to a bleed. Thromboxane A2 is the chemical signal that makes those platelets sticky. It is the megaphone that tells them to clump together and form a plug.
Okay, so what does the aspirin do to the megaphone?
When you take aspirin, it acetylates the COX enzyme inside the platelet. It permanently alters its physical structure. It disables it completely.
Permanently, like it can never work again.
Yes, and this is the crucial biological key to why aspirin is so effective. Platelets are unique. They don't have a nucleus. They don't have DNA to make new enzymes.
So they can't repair the damage.
Exactly. Once aspirin hits a platelet and breaks that enzyme, that specific platelet is poisoned in a good way, for our purposes, for the rest of its entire life.
And how long does a platelet live?
About 7 to 10 days. It can no longer get sticky for its whole lifespan.
That is wild. So even though the aspirin itself might be flushed out of your bloodstream in a few hours, the anti-clotting effect lasts for a week.
Exactly right. That is why a simple daily dose works so perfectly. You are constantly suppressing the stickiness of the new platelets as the bone marrow produces them.
The trial protocol called for 160 milligrams of aspirin, which is basically half of a standard adult aspirin, or about 2 baby aspirins daily for a month.
A very standard low dose today.
But the instructions for the very first pill in the hospital were highly specific. The protocol said the pill had to be crushed, sucked, or chewed. Why couldn't the patient just swallow it with a sip of water?
Pharmacokinetics. Speed of absorption.
Okay, explain that.
If you just swallow a pill whole, so specifically an anticoated one like they use in the trial, it has to travel down to the stomach, survive the acid, pass into the small intestine, slowly dissolve, and then get absorbed into the portal vein.
Which takes time.
That whole process can take hours before you get peak levels in the blood. When you actively chew the tablet, you mechanically break that protective coating. You vastly increase the surface area of the drug. Some of it gets absorbed directly through the mucosal lining of the mouth, under the tongue, and the rest hits the stomach completely exposed and ready to go. You achieve therapeutic blood levels in minutes instead of hours.
And as we said, in a heart attack, minutes matter. Every minute is dying heart muscle.
You want to slam the brakes on that clotting process immediately.
So we have the two tools. We have the hammer, which is streptokinase, to smash the existing physical clot. And we have the shield, which is aspirin, to stop new sticky clots from forming over the wreckage.
That is a very good analogy.
And of course, for the control groups, they had the placebos to match.
Right. They used a white powder dissolved in a saline infusion that looked exactly like the streptokinase bag, but had no active ingredient. And they used enteric-coated starch tablets that looked and tasted like the aspirin, but did nothing.
True double-blind. The doctor doesn't know, the patient doesn't know, the nurses don't know.
Only the central computer knows.
All right, so 17,000 people are randomized over a few years. The trial runs its course. The data finally comes pouring in. Let's move to section 3. The main results. This is the moment of truth for cardiology.
And the results were, frankly, stunning. In the history of modern clinical medicine, we very rarely get answers that are this clear and unambiguous.
Let's start with the big one, the vascular mortality at 5 weeks. This was their primary endpoint. Did the drugs actually save lives? Let's look at the streptokinase alone group first.
Okay, so comparing the group that got the real streptokinase infusion against the group that got the placebo infusion, the death rate dropped from 12.0% in the placebo group down to 9.2% in the treated group.
12% down to 9.2. That is roughly a 3% absolute difference.
Which to a layperson might not sound like a massive leap. 3%.
Right, it doesn't sound like a miracle cure.
But when you do the math on the relative risk, that is a 25% relative reduction in the odds of dying. If you treat 1,000 people, you are saving about 30 lives that would have otherwise ended.
And statistically, was it robust?
The p-value, the probability that this difference was just a random fluke of luck, was less than 0.00001.
So it is absolutely definitive. The bacterial protein works.
It undeniably works. It recanalizes the blocked artery, restores the blood flow, saves the dying muscle, and saves the life.
Now let's look at the aspirin alone result, because this is the one that I think truly shocked the medical world the most.
It absolutely did.
Yeah.
And you have to remember the context. Streptokinase is a serious, intensive IV drug administered by professionals. Aspirin is a penny tablet you buy at the grocery store.
Right. So what did the penny tablet do?
The aspirin alone group saw their mortality drop from 11.8% in the placebo group down to 9.4%.
Wait, that is almost exactly the same benefit as the heavy-duty IV drug.
It is virtually identical, a 23% odds reduction. Also highly significant, with a p-value less than 0.00001.
So the humble aspirin tablet was punching way, way above its weight class.
It turned out that stopping the platelets from aggregating and clumping was just as critical to survival as dissolving the main fibrin mesh.
So imagine the scene in the data center. You have the lead researchers looking at these two separate graphs. Both drugs clearly work independently, but the massive question, the entire reason they bothered with the complicated factorial design, is what happens when you combine them?
Right.
Does 1 + 1 = 2, or does it equal 1.5 because of diminishing returns? Or, worst case, does it equal 0 because combining a clot dissolver with a platelet poison causes everyone to suffer a massive fatal bleed?
This was the true aha moment of the trial. The data for the combination group, the patients who got both real streptokinase and real aspirin, showed a mortality rate of just 8.0%.
8%.
And you compare that to the neither group. The poor souls who randomly got the double placebo, they had a mortality rate of 13.2%.
13.2 down to 8.0. That is a massive, highly visible gap.
When you run the statistics, it calculates to an overall odds reduction of 42%.
Hold on. Let's just sit with that number for a second. 42%.
Oh.
Nearly half. You cut the death rate almost in half with one IV and one chewed pill.
It is staggering. It implies that the biochemical mechanisms of the two drugs are truly independent and beautifully additive.
They don't get in each other's way.
Not at all. Streptokinase acts like a snowplow. It opens the road.
Yeah.
And aspirin acts like the salt truck. It keeps the road from icing over again. They don't step on each other's toes. They work together perfectly.
If you translate that 42% into real human lives saved per thousand treated.
The paper explicitly does this calculation to make it practical for doctors. Using both active drugs prevents about 50 vascular deaths per 1,000 patients treated, compared to using neither drug.
50 lives for every 1,000. So if you are in a busy urban hospital seeing 500 heart attacks a year, that is 25 people actually walking out the front doors to their families who otherwise would have been carried out the back.
Every single year.
And we're talking about long-term survival here too, right? Because sometimes in medicine you see a catch-up phenomenon.
Oh, yes. That is a very real fear in cardiology. You manage to save them today in the ICU, but their heart muscle is so severely damaged and weakened that they just go into heart failure and die a month later anyway.
Right, you just delayed the inevitable. Did ISIS-2 look at that?
They did. The study followed up with the patients for a median of 15 months, and the survival curves on the graph stayed widely separated. The paper explicitly notes that early gains persist.
So the lives saved at week 5 were still saved at month 15.
Exactly. If you save that crucial heart muscle in the first hour of the attack, you don't just buy them a few weeks, you buy that person years of meaningful life.
It's just incredible. But the paper doesn't just stop at saying give the drugs. It digs into a much harder question, which is when do we give the drugs? Section 4 covers the time window.
This is where they really challenge the existing dogma of the time.
Because there was this intense belief back then called the golden hour, right? Or at least a strict belief that you had to be extremely fast.
Yes, the rigid belief was based mostly on early animal models experiments, mostly involving dogs and rats in the lab.
What did those models show?
In those experiments, if a researcher manually tied off a coronary artery, the heart muscle downstream of that blockage would die completely and irreversibly within about 3 to 6 hours. They called it a wavefront of necrosis.
So it sweeps across the muscle and then it is just dead tissue.
Right, so the prevailing clinical logic was, if the human patient arrives at the ER at hour 7, the muscle is already dead. There's physically nothing left to save. Therefore, giving them a potentially risky clot buster is all risk and absolutely zero benefit.
So the treatment door essentially slams shut right at the 6-hour mark.
That was the firm theory. But the reality is, humans aren't lab rats. We have much more complex anatomy, including collateral circulation.
What is that?
It is a network of tiny backup blood vessels. When the main highway gets blocked, sometimes these little side streets can trickle just enough blood to keep the tissue barely alive ischemic, but not dead for much longer than we thought.
So ISIS-2 tested this assumption directly. Let's look at the data they found by breaking down the results based on time since the symptoms started.
Right.
So 0 to 4 hours, the early birds who rushed straight to the hospital.
Massive benefit here, as expected.
Yeah.
A 53% reduction in mortality for the combination therapy. If you get there fast, you save a tremendous amount of heart muscle.
Okay, now the next group. 5 to 12 hours. This is the zone where a lot of doctors in 1985 would have hesitated or just said no.
Surprisingly, there was still a highly significant benefit, a 32% reduction in mortality. This definitively proved that the rigid 6-hour window was completely wrong. There was still salvageable living muscle at hour 8, hour 10, even hour 12.
And then we get to the latecomers, 13 to 24 hours. These are the people who, felt chest pain during dinner, went to sleep hoping it was just bad indigestion, and woke up the next morning still in agony.
Previous medical wisdom absolutely dictated, do nothing. Send them to a bed and watch them.
But the ISIS-2 data...
The data showed a 38% reduction in mortality in this late group for the combination therapy.
Wait, really? Even a whole day later?
Yes. Now, I have to put my statistician hat on here for a second. The confidence intervals for this specific late group were much wider because there were fewer patients who arrived that late. So the exact percentage of 38 is a bit less mathematically certain than the earlier groups.
Understood. But the trend was still clear.
The trend was undeniably clear and positive. The expert analysis in the paper argues that while earlier is obviously much better, the treatment window is vastly wider than previously thought.
It suggests the door doesn't slam shut. It just closes very slowly.
That is exactly the takeaway. It meant that a doctor shouldn't just look at their watch, see it's been 14 hours, and write the patient off. It radically expanded the eligibility for this life-saving treatment to thousands of patients who were previously ignored.
That is a massive paradigm shift. But as we know, we have to talk about the cost of doing business. These aren't sugar pills. They have real side effects. So let's dive into Section 5. Safety.
Safety is always the flip side of the efficacy coin.
You mentioned earlier that streptokinase is a systemic lytic. It dissolves clots everywhere in the body. That inherently sounds very dangerous.
It is. The primary overriding fear with any fibrinolytic is catastrophic bleeding. If you have an active stomach ulcer or a recent surgery wound or even just fragile gums and we turn off your clotting system, you are going to bleed.
So how bad was it in the trial?
The trial quantified this very carefully. Minor bleeds, which they defined as oozing from IV puncture sites, nosebleeds, or microscopic blood in the urine, were fairly common. About 3.5% of patients with streptokinase had them, versus about 1% with the placebo.
Annoying and scary for the patient, but not fatal.
Right. The major bleeds, those requiring an actual blood transfusion, were the real concern for the doctors. That rate was 0.5% with streptokinase versus 0.2% with placebo.
So a small absolute increase.
Yes, about 3 excess major bleeds for every 1,000 patients treated.
3 extra bad bleeds per 1,000. But we established earlier it saves 50 lives per 1,000.
Exactly. That is the fundamental risk-benefit calculation of medicine. You trade a very small risk of a severe bleed for a massive proven chance of surviving a fatal heart attack.
What about the absolute most feared complication? Bleeding inside the brain. A hemorrhagic stroke.
This is the nightmare scenario for any ER doc. You save the patient's heart, but you destroy their brain in the process.
Did the data show an increase?
It did show a very small early excess. On day 0 and day 1, there was a slight excess of cerebral hemorrhage with the streptokinase group. Yeah. 0.1% versus 0.0%. So it was a real tangible risk early on.
Right.
But, and this is a fascinating medical paradox, heart attacks themselves naturally cause strokes.
How so?
When a section of the inner heart wall is damaged and stops pumping properly, blood pools in that chamber. It stagnates. And stagnant blood forms clots.
And then those new clots get pumped out.
Exactly. They get ejected into the aorta, travel up the carotid arteries, and lodge in the brain. That is called an embolic stroke. It happens days or weeks after the initial heart attack.
Ah, I see where this is going.
Right. Streptokinase and aspirin profoundly prevent those embolic clots from ever forming in the damaged heart. So later in the hospital stay, the treatment group actually had far fewer strokes than the placebo group.
So you have slightly more bleeding strokes early on, but you prevent a bunch of clotting strokes later on.
Exactly. And when you add them all up to look at the big picture, total strokes of any kind were 0.7% with streptokinase and 0.8% with placebo.
So the treatment didn't actually increase the total stroke risk at all.
It just shifted the timeline of the types slightly. But overall, it was completely stroke neutral.
That is incredibly reassuring data. What about the aspirin safety profile? People always worry about daily aspirin causing stomach ulcers.
It's true that aspirin at high doses over a long time causes gastric irritation. But the trial protocol was just 160 milligrams for only 1 month.
A short course.
Right. The paper found absolutely no significant increase in major bleeds or cerebral hemorrhage attributable to the aspirin alone. It was remarkably wonderfully safe.
There is one other paradox in the safety results I really want to unpack here, reinfarction, which just means having a second heart attack while you are still recovering from the first one.
Yes, this is a crucial piece of the puzzle.
The data showed that giving streptokinase alone actually increased the rate of having a second heart attack while in the hospital. How is that even physically possible? You literally just chemically open the artery.
It seems backwards, right? But think about the physics and the biology of it. You use the drug to dissolve the fibrin clot. The artery is open again. But what is physically left underneath that dissolved clot?
The original blockage.
Yes, a ruptured cholesterol plaque. A raw, ragged, highly sticky, damaged surface inside the vessel wall. And furthermore, when the streptokinase wears off after a few hours, your body naturally has a massive rebound spike of thrombin, which is a powerful clotting factor floating around in the blood.
Because it's trying to recover from being chemically altered.
Exactly. So the body sees this raw, bleeding surface in the artery, throws a bunch of hyperactive platelets at it, and boom, it tries to heal the wound by aggressively forming a brand new clot in the exact same spot.
It's a violent rebound effect.
Precisely. The cure, aggressively opening the vessel, temporarily creates the perfect storm for the disease to rapidly return.
And this is exactly why the aspirin is so vital.
You nailed it. In the combination group, the aspirin poisoned those platelets so they couldn't react to that raw surface. It prevented the rebound entirely.
So the reinfarction rate
Was lowest in the group that got both drugs, 1.8% versus 2.9%. Streptokinase forcefully opens the pipe, Aspirin smoothly coats the pipe so it doesn't instantly clog right back up.
It is so amazing how the microscopic biology matches the macro statistics perfectly.
It really is satisfying as a scientist when the physical mechanism perfectly explains the clinical math.
Now, we are moving to what is possibly my favorite part of this entire paper, and certainly the most famous section for anyone who studies statistics or clinical trial design, Section 6, the astrological subgroup analysis.
I love this part. It is legendary in academic circles.
Honestly, I laughed out loud when I read this, but it is actually making a deeply serious point.
It is. Smack in the middle of this incredibly dense life and death medical paper in The Lancet, there's a formal data table breaking down patient survival by their zodiac sign.
Why on earth did they do that? Did the lead researchers secretly believe in horoscopes?
Huh. No, quite the opposite. They did it intentionally to demonstrate the profound mathematical dangers of something called subgroup analysis.
Break that down for us.
Here is the statistical trap. When you have a massive data set of 17,000 people and millions of data points, you can slice that data a million different ways.
Right.
You can look at men versus women, old versus young, diabetics versus non-diabetics, smokers versus non-smokers.
And what's the danger in that?
The danger is the law of probability. If you look at enough different subgroups, purely by random mathematical chance, you are guaranteed to find a group that looks vastly different from the rest.
It's like looking at clouds. If you stare at the sky long enough, eventually you will see a cloud that looks exactly like a bunny rabbit. It doesn't mean there is a giant rabbit made of water vapor living in the sky.
Exactly. It is a statistical illusion. We call it multiplicity or data dredging.
So the researchers wanted to prove how easy it is to fall into this trap. So they asked for all the patients' birthdays and ran the survival analysis based on astrological birth signs.
They did. And the results they found were mathematically hilarious. They found that for patients born under the signs of Gemini or Libra, the aspirin didn't work at all. In fact, for those two signs, taking aspirin appeared to increase their mortality by 9%.
Bad news for the Geminis.
But for all the other 10 astrological signs, aspirin was strikingly beneficial, reducing mortality by a massive 28%.
So if you were a bad doctor who just blindly followed the p-values without thinking, you would take this data literally. You'd have a patient come into the ER with a heart attack, and your first question would be to ask for their birthday. Oh, you're a Libra. Sorry, no aspirin for you. The data says it will kill you.
Which is, of course, biologically absurd. The position of the stars in the sky at your birth does not somehow alter how the cyclooxygenase enzyme interacts with platelets in your bloodstream 60 years later.
So the researchers deliberately put this nonsense in the published paper to troll their own peers.
They did. They used it to say, look, we found a statistically significant difference for Geminis, but you all know it is complete nonsense. Therefore, you should be equally skeptical of other subgroups that don't make sense.
That is brilliant. What is the ultimate takeaway from that joke?
The core lesson is, you must believe the overall result, what we call the main effect. The main effect of 17,000 people is that aspirin works and saves lives. Do not get distracted by weird random deviations in small subpopulations unless you have a very strong, pre-existing biological reason to believe they should react differently.
It is an absolute masterclass in critical thinking. They trolled their own audience to teach them a vital lesson about statistics.
And it serves as a warning that stands true to this very day. Think about modern media. Whenever you see a news headline saying something like, "New study shows coffee causes cancer," but only in left-handed dentists who work on Tuesdays, you should immediately think of the Geminis in ISIS-2. It is almost certainly just statistical noise masquerading as a breakthrough.
That is such a good point for people to keep in mind. Let's move to Section 7, implications.
Okay.
We have established through massive data that the drugs work. We have established that they are safe enough to justify the minimal risks. Let's talk about the real-world impact. Economics.
This is arguably one of the most cost-effective medical interventions in the history of human health.
Well, let's look at the price tags. Streptokinase.
Streptokinase was an old drug by 1988 standards. It was generic, it was widely available, it was remarkably cheap to produce.
And aspirin.
Aspirin, well, it's aspirin. It literally costs pennies. The paper officially describes the cost of the aspirin intervention as negligible.
So for a few pounds or a few dollars, depending on where you are, you can unequivocally save a human life. Compare that to what was happening in the pharmaceutical market at the exact same time. There was a brand new, highly hyped drug coming out called TPA, right? Tissue plasminogen activator.
Yes, TPA was the new sexy, genetically engineered wonder drug. It was designed to be fibrin-specific, meaning theoretically it only targeted the clot in the heart and wouldn't cause bleeding elsewhere, unlike
It
streptokinase.
sounds great in theory.
It does. But because it was brand new biotech, it was 5 to 10 times more expensive per dose than streptokinase.
Wow. And did it work 5 to 10 times better?
At the time this paper was published, it hadn't been proven to be better at all. The ISIS-2 paper makes a very subtle but incredibly powerful point. We have a cheap, generic treatment that works right now. We do not need to wait for the expensive, fancy stuff to prove itself before we start saving lives today.
And what was the clinical impact globally?
It completely standardized care. Before ISIS-2, treatment for a heart attack was highly fragmented. One hospital might do lidocaine, another might do beta blockers, another might try an early version of angioplasty.
A total roll of the dice for the patient.
Exactly. After this paper, the combination of aspirin plus a fibrinolytic became the absolute, unquestionable standard of care for what we now call a STEMI, an ST elevation myocardial infarction everywhere in the world.
It is hard to even wrap your head around the numbers, but this one single paper likely saved millions of lives over the subsequent decades.
Millions. Easily.
Yeah.
It changed the fundamental mindset of emergency cardiology from wait and see to act immediately.
And that brings us right back to the uncertainty principle we talked about earlier.
Right.
Because the conclusion of the paper basically emphasizes that the overwhelmingly positive result of the trial means that in almost all cases of clinical uncertainty, the treatment should just be given.
Yes. The math proved that your hesitation is more dangerous than the drug. Inaction is not a neutral, safe choice anymore. Inaction is actively harmful.
So wrapping up the data from the paper itself, the conclusion is just beautifully stark and simple. Streptokinase alone reduces mortality. Aspirin alone reduces mortality. The combination reduces mortality by 42%. And those life-saving benefits persist for years.
It is the gold standard.
Yeah.
It is what every single clinical trial designed today aspires to be. Clear, large, and completely definitive.
As we close out this deep dive, I want to take a moment to reflect on the modern context, because we live in an age of incredibly complex, personalized medicine, right? We have CRISPR gene editing, AI-driven diagnostics, targeted immunotherapies. We are deeply obsessed with complexity.
We are.
But ISIS-2 was entirely about simplicity. A one-page entry form, a phone call to an operator, 2 cheap, widely available drugs.
It serves as a stark reminder that high tech isn't always the only answer or even the best answer. Sometimes the most profound medical answer is just high volume and rigorous, uncompromising testing of the basics. ISIS-2 succeeded precisely because it forcefully stripped away all the academic bureaucracy to focus relentlessly on the core question.
It makes you wonder, could we even do this today? Could you run a trial with 17,000 people across 16 countries using a one-page form and verbal consent over a telephone?
That is a very provocative question, and the honest answer is probably not.
Because of the red tape.
With modern regulations, HOPA in the US, GDPR in Europe, the massive multi-page informed consent documents, the intense data monitoring requirements from ethical review boards, a trial as simple and fast as ISIS-2 would be incredibly difficult, slow, and astronomically expensive to run today.
Which is a double-edged sword. We have obviously gained a lot in terms of vital patient protections and privacy.
Absolutely. Those rules exist for good reasons.
But we may have inadvertently lost the ability to answer simple, massive questions quickly and cheaply.
We might be missing the low-hanging fruit in medicine simply because the regulatory ladder required to reach it has become too heavy and expensive to lift.
How many other aspirins are just sitting on the pharmacy shelf right now, unproven for a new disease, simply because no researcher can afford the $500 million trial required to legally test them?
That is a thought that will definitely keep me up at night.
Me too. The lesson of the Geminis, the absolute power of large numbers, and the incredible world-changing potential of a simple, crushed aspirin tablet. It has been a truly fascinating journey back to 1988.
It really has. A potent reminder that sometimes the biggest scientific breakthroughs come from simply organizing the data properly and trusting the numbers.
Thank you for watching The Funnel Effect.